So hello and welcome to the Vet Rap podcast. Here in our new, very exclusive ERH studio. This is the first recording in this venue, and actually also the first podcast that Arthur and I have done together.
Yes.
So welcome, Arthur, to your podcast.
How's that happened?
I don't know. I think you or I have been away most of the time, or
you or I have been the interviewer.
Yes.
Not the interviewee.
Yes. So this is going to be a dysfunctional conversation with two interviewers and no interviewees. So that's going to work. So look, we thought we might address, I guess, a slightly grey definition of today's podcast, but it's essentially managing complications in the hospital setting and managing complications, in any surgery, not a specific surgery, more just from the point of view of how we manage our complications, because it happens to everyone. Everyone will get complications. If you don't, you're probably not doing enough surgery. But from the point of view of how we approach the case and any tips we can come up with that might help.
Mindset. Yeah, because they can break you.
Yes.
So all right. Now,
I have a list,
organised,
very, very quickly written list of things that we might want to talk about. And I have top of my list here, educate the client.
Yeah.
This, from the point of view, I'm just introduced the topic. I feel like this is from the point of view of actually heading the complication off at the pass almost. The complication is always a stressful event, but the worst complication is when you've blindsided a client.
Well, for me too, because it comes back to training surgeons as well, is that educating the client, you're actually educating yourself. It's like that reminder, we did a PDA today and the conversation with the client was, your dog has a 5% chance of dying, but it stops me and makes me go, your dog could die, we may fail to ligate, it could recanalize. You get a post-op infection and you're thinking, what are all the things that I haven't thought of as you're talking to the client? So it's actually getting me ready for the surgery as well. But couldn't agree more. The worst complication is when you fail to mention it.
Yes.
Yeah.
Absolutely.
So I've got the ball this time.
Okay.
how in a 45-minute consult?
Yeah.
Well, doesn't matter how long. Yes. How much of your consult is talking about complications?
Obviously, to some extent depends on the case.
Yeah.
And obviously, there's a clinical examination, orthopedic exam, whatever. It'll be 2/5 of the consultation, or there'll be about talking about consultation. Yeah, I would think so.
Yeah. Well,
generally.
Yeah, cool. Because for me, I feel I never tell people the great outcome because they love that bit.
Yeah.
But I do spend up to half of a consult could be just going through the what's going to go wrong, or expectation of setting the bar. Because I think that sometimes that can be a complication. Let's talk about elbow dysplasia. They always have a degree of lameness. Now that could be perceived as a complication, but actually that's a reality of the disease. So
that's about education, isn't it? That's
back to education.
Yeah. And therefore setting the bar of expectations, but also reality.
Yeah.
I think it's a very common one we've talked in the past about lump removals, and we get, as a specialist, you get referred a lump to, this is not something that we can take on. It needs to be go to a specialist. And generally speaking, a lot of those cases we're not pulling a magic bean out of the bag and going, of course we can do this amazing technique and grow some skin and stick it back on the dog and a fully functioning carpus. We're just saying, look, this is what's possible.
Yeah, that's right.
And this could, things may go wrong. One of my favourite, for better or for worse, complications to literally put on a consent form is failure to cure cancer. I write it, literally write it down.
Mine is ongoing lameness.
Yes.
For all the orthopedics, because that's a reality. TPLOs can have ongoing lameness.
They can.
Yeah. So yes, from a perspective of being empowered as well, we document all of, as many as we can think of, but all of the complications on our consent form. So we have a reference point as well. Yes. So, if we're having a challenging conversation later on because things aren't working out. Not that I've ever had to do it, but we
pull
can
it
reference
out.
back.
Yes, I've never had to do that.
No,
but
but it's and maybe that's a good thing. Maybe we talk about it enough. But I never consider discussing the potential of complication as a failure as a surgeon. I own it. It's like, I'm going to do this for you, and here's a list of things that can go wrong. And they do happen, and I have seen them.
Yes.
And I never have sort of sat in a consult room thinking, I'm underselling myself. It's like, this is just a factual conversation.
Yes.
Yeah. It's not like I'm not good enough. It's just things we know, the literature tells us.
Yes.
This is the list.
There are risks.
Yeah.
They are described.
Yeah.
But it is still a valuable thing for your pet to have this procedure.
Yeah.
And I think also, once you've gone through the complications, bringing out the fact that you're not going to run away, after the surgery. You're going to be around to support them through that process because you've probably dealt with some of these complications before.
Yeah. Yeah. Which actually demonstrates the experience that you have or haven't had.
Yes.
Yeah.
And the fact is that you can, no one likes a complication. Everyone hates it. The client wants their pet to be pain-free and healthy.
Yeah.
But the fact is that as a vet, your job is not just, it's just not black and white. It's far too grey, and you have to be around to manage what you're, and have to let the owner know that that's possible.
This is going off track, but this is what we do, isn't it? The other thing I like about talking about complication is not only so that the owner was educated and informed before it happened, is that it often leads me to a statement that I use frequently, which is the risk-benefit ratio or a relationship. It's like, this is a really low impact procedure with very limited risk. It might not but it may not create a profound outcome for your pet, but relative to the benefit versus the risk, it's worth doing.
Yeah.
Or this is a really big impact procedure, ton of risks. The benefit to your pet is questionable.
Yes,
and
exactly.
it's sort of, I think it not only empowers the owner around what might go wrong, but about choosing whether it's right for them and their pet, because you've been really clear about this is how much I can achieve for you and this is how horrible it can go.
Yes.
And it's a really big hole, or the opposite, it's a very small hole, but it might not be that fantastic.
And I think that brings on to point 2.
Yep. Keep moving along.
Moving along. But I think what I wrote down on point 2 is educate yourself.
Yeah.
And I think from the point of view of there are some things that you're going to take on, GP or specialist, whichever field, wherever you are, that are just on the edge of where you're comfortable.
Yeah.
And those are the ones where I think you need to double down and really educate yourself on what could happen, and plan for it actively.
Yes.
I mean, I'm not going to name a name, but I do remember a couple of times being called through the GP group at Penn Vet Care before we had ERH. And there was a wound that someone had taken a lump off and they couldn't close.
Yeah, that's a classic.
And I turned up and the clip was like a centimetre away from where the lump had been. And there was a fenestrated drape
there.
And it's like, well, you know better than this. This is, before you started.
Yes, but and that example's very common, really. But here's another example. Again, educating, and you've been through it, but educating people through residency.
Educating the impossible to educate.
Well, yeah, your words. That's Christopher. But if you think about it, if I sent you away, so you want to do something new, and I sent you away, which I sort of did sometimes, and said, go and think about what's going to go wrong. How much value was that to you from an educational perspective rather than tell me how amazing it's going to be?
Yeah.
It's vastly better, isn't it?
Yeah.
When you actually look at the going wrong, you learn so much more about the whole lot, not even just how to do the surgery, but the the disease process, the pathophysiology, et cetera, because you need a lot more knowledge to understand complications, I think.
Yes.
It's sort of...
Yeah, because particularly perhaps especially in orthopedics, it can be cookie cutter. Like it's like, I have done that. I've done it.
Yes.
There you are. Everyone is going to be exactly the same as that one, which I did.
Yeah. Until the TTA explodes into a complex tibial fracture.
Yes.
Ow.
Yes.
Yeah.
Not even
Not that
vaguely
I do
starting on that
TTAs.
one. Unnecessary jibe on the anyway. But yeah, educating is really important. I mean, it's probably maybe those two are the wrong way around, but either educate client, educate yourself.
But the two go together. Yeah. All right. So we could summarize that into start with your best foot forward.
Yes, a little bit.
And don't shy away from the conversation. It's not. I think some people think if I talk about complication, they won't want me to do the procedure. So no, I think it's actually showing that you know what you're talking about.
Yes.
Yeah.
That's a mindset.
That is a mindset.
Yeah. And it's one that, as a surgeon, you probably have to develop quite quickly, I think. And that brings us to
number three.
Number three, which is down the bottom of here, because I thought this might fit in here, but maybe not. We're going to fit in here anyway, which is being proactive. This is probably after the event when the complications occurred.
All right.
And actually how, as a surgeon, we would, I guess, manage that situation.
Always be in front of the client. I do not. For me, a complication is a practice building experience or practice breaking. It's like if you go, yep, I own that. Yes. That is a complication. So I think that's the first step. Like, yep, that's definitely a complication. No, it's not because your dog ran around the back garden. No, it's not because you forgot one antibiotic or whatever, which is sort of the easy opt out.
Yeah.
It's like, no, that's a complication. We need to fix it.
Yeah.
First step.
Yes.
Be in front of the client.
Yes.
It's often can be emotional. It's very frustrating. I will often say to people, we don't like complications. The pets hate them. You just want your pet to get better, and we want your pet to get better because this is what I do every day. Yeah. And looking at this not doing well hurts me.
Yes.
A bit of honesty,
Yeah.
It's like, I'm hating it too. So why don't we together sort this out?
Yeah.
That's the language I use.
It is.
Yeah.
It's running away. It's tempting. It's tempting
God,
how tempting is it? Let someone else deal with it, or But you're right. Some of the most bonded clients I have long term, I've probably had issues with their patient at some point or other, and it's become the journey that actually we got there, and it's just going to happen.
It just demonstrates that you really are committed to their pet and you want that outcome for them. And it is. It's there's days where you certainly want to crawl into the corner and rock, but you can't. You've got to get out there and sort it out. The language too. I say to people, sometimes, and we're going to talk about complications coming from elsewhere that aren't your patient, but it's like this has happened and that's behind us. Can't change it. So what we need to do is start talking about where we're going, not what's happened.
Yeah.
And it can apply to your own complication or someone else, but keeping the forward direction. And I think not that I've experienced being the client with my own dog having a complication, but I think that level of
my OCD Salukis wing broke down. It was just very disappointing.
but in a way, knowing the plan helps you cope, doesn't it? Yeah. This is what we're going to do about it, and this is the journey. That wound breakdown is don't re-suture it. That's going nowhere. It's definitely 2 to 3 weeks of ooze around the house on the white carpet and the Persian rug and the silk sheet.
Both of which I obviously have.
I was waiting for that.
All 3.
Yeah. Anyways. Making sure people know where you're going to end up.
Yeah. Yes.
Yeah.
Being proactive, is largely not giving into the temptation to hide from that.
Yeah.
And as you say, getting in front of the situation and actively, finding a solution and supporting. Being open-minded, I had up next, which I guess what I meant by that is keeping an open mind about what could be going wrong.
Yes.
Because it's not always obvious. I mean, sometimes it is. But, when it's your case and you're already emotionally invested in that case because you started the process, it's very easy to get blinkered by what you thought might have been going on last time you saw it and go, well, and you almost treat the dog as not the dog that's in the room right now looking at you, as the last consultation version of the dog that you thought was going on. And that's a pattern that recurs multiple times.
And you can find yourself doing the same thing over and over again.
Yeah.
Yeah. So on that, I can't read that. But
well, you're not supposed to be able to read
that. Yeah. But on that, I think we had a point there was start from the beginning.
Yes, exactly.
So be open-minded. So, okay, this looks like post-op infection.
Yeah.
And let's talk TPLO. The dog's not doing well. Looks like a post-op infection. So take the plate out, culture it. You grow something, you put it on the appropriate antibiotics, goes away, and then there's actually a case that's knocking around right now.
Yeah.
And then the dog's suddenly non-weight bearing lame.
Yeah.
You can stay on that path of it's a post-op infection, but you've got to train yourself to, be open-minded and to be prepared to come right back to the beginning and as if you've never seen the pet before and sit down and redo that consultation as if it was the initial consultation.
Yes.
And that definitely gets you out of trouble.
Yes.
Like it's very easy to get stuck on this complication occurred and this is why we're not achieving the outcome, but things change.
And to some extent, recognizing that a complication, I mean, if you saw a patient you hadn't seen before, what's the first thing you'd do? You would read through the history to that point.
Yeah.
You'd read through its history, whatever you do it, you'd definitely have an idea of what's gone on before so that you can, come at the case with some education. But a complication is a new disease process often for that patient.
Yeah.
So it should be looked at as such. It's
an initial consultation, basically.
Essentially, you have to go back and consider, it's going to take you time to sort this out.
And what you have to remind yourself, if you don't get the outcome from the management of that complication, then you need to start again because you were on the wrong path.
Yes.
Which takes quite a high level of self-discipline, doesn't it? Yeah. It's like, okay, it's a complication, so I don't feel great about this case and the owner's not feeling great about it. Yeah. We've done a bunch of stuff and it's still not working. Yes. So now I have to stop and redo that process all over again and go through that, the potentially increasing frustration on everyone's behalf. Yes. But you've got to stop the process and start again. Yeah. And you're going to say, reach out, i.e., talk to other colleagues around you or, whether that's another specialty like a medicine department or whether that's external to your facility.
And I think that probably is something to add in here is there are times when a bit of humility is required to get the result that needs to happen for everyone.
Yeah.
And sort of accepting that at this point you can't really add a lot more to the conversation, and it may be worth just referring.
Well, I think that's still the same as getting in front of the client, which is counterintuitive, isn't it? I have a complication, I'm going to fix it, and you can get that sort of fixation error where you just can't see anything else. Yes. But getting in front of the client doesn't mean you have to solve the problem. You just have to make sure you've facilitated the problem being solved. So that in my mind, I am going to the medicine service and having a discussion, and they've said to me, you should go, you should take a pet and they need to evaluate the dog fully. Excellent. Geez, that makes me happy because it's like this sense of relief, isn't it? This is out of my remit. I'm not skilled in this. Yeah. This dog needs someone else. Phew, I found a solution.
Yeah. And I think, this is probably getting slightly off topic, but I remember there was a period in my career when I perceived there might be a danger of asking someone else's opinion that you would then be judged.
Yeah.
And making that something that I would therefore try and hold on quite a lot to cases, as a result of a fear that, and I don't believe that is our culture as a profession at this point. And whether it was in my mind 20 years ago or not, I don't know, but it certainly was in my mind.
My take is you're most likely to be judged by someone who doesn't have much experience. Because if you've done enough of this, you've seen all those things happen and you're just like, oh, yep, done that, been there.
Yes.
Yeah. Like it's a nature of the beast. I mean, that's why so many every case series of every disease that I've ever read, part of the case series is what went wrong. Yeah. Because there's always something.
Yes, absolutely.
Yeah.
So number 5 on my list is possibly being honest now. How do we charge for complications?
We charge in a way that makes us feel better.
Yeah.
Yeah. Well, or was that not fair? I don't know. No. We charge in a way. Well, the way I look at it is, you're the owner, and here's the pet stuck in the middle between two of us. Yeah. And in a way, you and I shook hands and made an agreement at the beginning. Yeah. You entrusted me to do a surgery on your pet.
Yes.
I informed you of what might go wrong. Yeah. So I've heard some surgeons say, well, I informed them, so therefore it is all your liability as the owner, because you knew, you went into this with eyes open.
Yeah.
My take on it is, you trusted me with this, a complication happened, I did inform you, we know it happens, but we're in it together, we need to sort this out.
Yeah.
So I do absolutely, and I know you do too, modify charging such that both parties are happy.
Yeah.
Now, it is a little flexible, I guess, but it's really, I look at it as the outcome we're all after is your pet is better.
Yes.
So how do we get there?
Yeah.
And I think that's just a discussion. And obviously, costs have to be covered, absolutely, and there's no way around that bit. And as long as I inform the client fully, then I think it's highly appropriate to ask for costs to be covered, but I don't need to profit from it, that's for sure. Yeah. But I don't know how, I don't think there's a structured way of addressing this question.
Very challenging.
Yeah.
I mean, you do have to, I guess from my point of view, I wrote this down because I thought, well, you do actually have to charge. Like, you can't.
Oh, absolutely.
You're not falling on your sword and it's all my fault, I'm really sorry.
That's a disaster. Yeah.
That isn't what this is about. And you want to separate those two things anyway.
Yes, because you're not a functional clinician if it's all my fault. You're no longer actually providing a service, you're just blaming, which is the worst place to end up.
And you won't be keeping an open mind if that's what you're doing.
Absolutely. You're actually no longer fit to be that pet's clinician.
Yes.
You should be handing that along. And my other observation with not charging is it actually can create a situation where the pet suffers because money focuses our minds.
Yeah.
So things keep getting done and done and done. The dog was never going to get better.
Yes.
So we should have had a difficult conversation right at the beginning. This complication has happened and it is the end of the path. Yeah. So it's an amputation because the chances of retrieving this scenario, or it's a euthanasia, which was horrible, but hey, it's not reasonable to keep going. But when you take money out of it altogether, it nearly becomes it's, you've got to keep going. It's like, but that's not appropriate always. There has to be a charge, absolutely, because it is, if it's been properly discussed and acknowledged before the surgery was done, every party is, responsible in the wrong word, but committed to the process. So we all have to, participate in our own way. And the financial bit is the owner's participation plus their care of the pet at home, of course. But us being reasonable is our commitment to getting better. I hadn't thought of it that way, the free thing, because I've not done that for such a long time. But we've all done it, and it's always a disaster.
It is, absolutely. And the final 2 points I had on this one kind of probably tie in together slightly, but they are different. How does one take education out of a complication? How do you learn from what's happened? And what process can you apply to the complication that actually makes you feel like you've actually maybe grown as a clinician? Or
I think there's two ends of this spectrum. It's like the charging conversation. Not charging's bad. Charging at full money is probably inappropriate. So with regards to how the education, how do you learn? One end of the spectrum is crisis mode. I'm never doing it again. The other end of the spectrum is, complications happen, so it's absolutely fine that I keep having complications. So neither of those are good. I think it's having the capacity and working in an environment, the support of your colleagues, to critically review, to ask without emotion, what was the path that led to the complication. Sometimes it's super simple. How did we get here? With the intention to see if there's an opportunity to change the way you work or your practice works to avoid that complication. Now, there may be answers that you come to a realisation that you have taken on a disease process or a surgical procedure that's outside the capacity of your facility and you as an individual.
Yes.
You know, open heart surgery in this practice would not work.
Yes.
Like they would, some might die. Well, many would die.
Yes.
One might live, but that's not appropriate, is it? You know, even though death is a non-complication of open heart surgery. But yes, so that's an extreme. But you know, that has to obviously is tiered up and down depending on where you are. It takes courage to do that, though, doesn't it? I mean, it's sort of tough looking, you know, what we call it M&M rounds. Yeah. But standing up and presenting that, you're sort of like, oh, put my rhino skin on and off I go.
Yes, exactly.
But it's actually sort of therapeutic too, because you then start having the conversations without the am I a bad person? It's like, this is what happened.
Yes.
And then you identify, okay, here was the opportunity for the complication to occur. Here was an opportunity. And the really good thing is at the end you get to a point where you're like, well, maybe we can avoid that. We'll never make a zero, but lessen that risk.
And it depends on what exactly we're talking about. I mean, certain things like go back to the TPLO thing, infection rates on a TPLO, one instance is not going to there's no education there at all.
No.
You know, a multiple over the odds incidents would trigger some sort of investigation, hopefully an appropriate one.
Yeah. That actually, sidetrack again, you know, that's why we have the clinical audit in place, isn't it? We document every single procedure we do and any complication that occurs to look for trends so that we can ask those questions. You know, we actually can critically review our performance. But you're right, one post-op TPLO infection, that's about 5% of cases. So we're not going to have a huge response to that. Yeah. But if our trend is going the wrong way, we're turning the place upside down to work out what's going on.
What's happening at that point.
Yeah.
And the final one I've got here, which I think really in some ways ties up with this, is self-preservation.
Very important.
Because managing complications as a vet and as a surgeon is extremely stressful, and it's important to recognise that. I think it can be. It doesn't have to be. And hopefully some of the things that we've talked about already help the process be less stressful from the point of view of, you know, the client is well educated and therefore is not in a immediate blame mode, and you're not in a blame mode because you've read your reviews and everything else. But over time, it can definitely. I don't mind admitting. I mean, Arthur had less time in general practice than I have done, but I left a practice in England where I was senior surgeon in an 8-branch group for 7 years, and was just about whacked out by the time I left. I was even wondering whether I wanted to be a vet anymore, from the point of view of the cumulative effect of managing everything for so long. Yeah. And my response to that personally was when I came to Australia and started again, I literally put down a list of surgeries that I'd performed in my career. And I listed by the side of them ones that I think my complication rate was about appropriate. Yeah. And those were the ones that I continued to do. To a point where local specialists, not Arthur, because he wasn't around when I started to talk about it, but local specialists used to comment that they hated seeing cases from me because they were always going to be complex. Because I'd cherry pick the nice ones.
Nice ones out, which is actually the place to put yourself. Yeah. I mean, even as a specialist surgeon, we do that. Yeah. Like, eyes and brains. Don't ask me about that. Yes. I'm just not going to touch that stuff. Yes. Yeah. It's just a disaster. Yes. Why go there? Yeah.
Do you have any tips? Any?
Well, I mean, I have said this to you when Chris, complications come in threes about every 6 months. Yes. Because they do beat you up, and I don't know why they do that, but they do. Yeah. And it's a case of, don't allow yourself to be highly reactive to a complication. I've had a complication. I can never do it that way again. A fracture repair is a great one. I did a fracture repair, the plate broke. So now, from now on, I'll put 3 plates on instead of 1. Yes. Yeah. Hopeless, because you're skewing your clinical judgment. Yes. But it's also like, but if you do enough fracture repair, a plate will break. Critically review that case as an individual. Yes. And recognise, try and document or determine how did that happen.
And the answer is seldom he went running in the backyard when I told him not to.
No, it's never that, is it? But but also, I mean, acknowledging that we're human. Yes. There's different types of error. There's an outright mishap. There's a lack of knowledge, or there's an application of the wrong information. Pattern spotting. That's what I do. Lack of knowledge is what young people do. Yeah. That's it. And so just recognising who you are yourself, and retraining yourself to try and avoid that happening again. But you actually the don't beat yourself up and look after yourself thing too. That's about making sure you've got the right people around you. I mean, you don't want someone who just pumps your tyres up when you're doing terrible things, but you definitely don't need people who sort of, feel it's okay to pile on in because one thing went wrong. So, it's finding the people that you can have a constructive conversation with to get to the correct conclusion. In your example before specialist training, of recognising that certain procedures you just don't want to get involved in because you weren't able to deliver the outcome.
That's right.
Which is not you as an individual often anyway.
Well, it's because the more, what's the word? Extravagant surgeries or whatever spectrum you want to do. I mean, I would list in that as, for example, a triple pelvic osteotomy as a really good example of something that I have taken on as a GP. Really probably shouldn't, because I didn't have the practical fracture fixation skills at that point in my career, really, to manage or to appreciate the subtleties of what actually I was doing at that time, and you get complications associated with it.
And the plates at the time were awful.
And the plates at the time were awful.
Absolutely
now they're locking plates, it helps a lot. The other thing that I have in this, which I think is, especially if you're in a GP clinic doing quite a lot of surgery. When I was an age, I did the
a younger man.
I did the English certificate in small animal surgery, and as part of that process, you had to do a case log.
Oh yes, that was always a bad
18 months of a case log.
Yeah.
And
that was so misdirected. Here you go, do all these complicated procedures on your own in practice so that you can sit an exam.
You're spoiling my point. I have to
Sorry. Okay. I did it as well. Come on.
Hang on, I keep pulling. There we go.
Christopher.
I've only got a very short lead here. My point was, after doing that, I recognised how many cases I'd managed that actually went really well that I'd completely forgotten about.
Yeah.
And as a result of that, continued to do a case log, because actually looking back and going, those 50 cruciates that I managed, I'm actually fixated on the one that I've been managing for the last 6 months because it's still got a problem.
Yeah.
But there's all those ones that actually went really well. Yeah. And being kind to yourself that way around, actually, I felt that the case log really helped.
Yeah. And that's why I sort of used to have frequently talked to people in training about, you're going to get 3 in a row. It happens.
Yeah.
It's don't let it break you.
Yes.
You just get back up, go and put yourself back in front of the client, turn this around.
Yes.
Critically review, but accept it. Like if it's part of doing surgery.
Because every job
has
a downside of some sort. Literally every job.
Yeah, it has to.
And I think we sort of feel like in some ways we shouldn't.
Yeah. Yeah.
It's just not the same thing. Obviously, it doesn't apply the same way, but every job has that.
Yeah.
Slightly uncomfortable side that you have to manage.
But there's actually a reward in sorting out your own complications, I think.
Yeah.
It's like, yep, they happen, not happy, but hey, I have, I can do this. We can sort this, or I can find someone to sort it for you. Yeah. No.
So increasingly in the world today, we might end up having cases that come to us for second opinions or have been managed by a traveling surgeon or whatever in your building, and you're having to manage those complications.
Yeah, so the case that comes to you that you weren't the primary surgeon, maybe the surgeon isn't in your practice, you might not even know them. Clients are often a little bit hot under the collar because they've actively sought an external opinion. So there's no relationship to. It's not I did the surgery and I've created this relationship, and hence it's an easier conversation. We obviously get a few of these, but these are a slightly different scenario, aren't they? Yeah. But I think these are a measure of, who you are, and actually whether there's a certain next step up on these. It's managing that whole scenario is quite different.
Yes.
Yeah.
And this, I mean, we've covered this already, but this is probably the scenario more than any other that going back to the start is an important first step.
Absolutely.
Because probably the client will come with some whatever's been said to them the last time.
Absolutely.
And you need to sort of go, yeah, okay, whatever you say, fine.
But I actually have to, you might have done this. I actually have to say to them, so why are you here? Oh, because my dog's leg's infected. It's like, that's great. Good. I'll ask you it differently. What did your dog do in the beginning? Yeah. And then they start telling you. And there's obviously nothing to do with an infected. Yes. But that breaking down that I've been told this, I've been told this, I've been told that, often many different things. Yes. And they come in and tell you the diagnosis, and you have to really utilise all those skills that you get as a vet with regards to accurate history taking to get them to wind right back to the beginning. Yeah. What is your dog actually doing? Yes. But it's more challenging, isn't it? Because they've got a head full of ideas. Yes. And man, they're just the end of you. If you get sucked down that rabbit warren, you are not going to solve the problem.
These can be very long consultations.
Oh yeah, easy hour.
You're starting with that preemptive thought process that's coming in with, and then you have to sort of stop that and then reverse the polarity slightly.
These are the rare consult where I find I actually have to say to people, I'm really sorry, I'm going to be a little abrupt, because they will not give up their whatever they've been told is going on. Because they're usually hanging on to that really tight. And I have to say, I'm sorry, I'm going to be a bit abrupt, but I need you to stop telling me what you've been told and start answering the question of what was your dog doing? Yeah. And they look at you like, oh, okay. It's usually all right after that. But I always feel a bit awkward. But I do find myself having to do that over, more often actually. Mm. And I always wonder, is this going to go horribly wrong? Yeah. And actually, they sort of look at you and go, oh yeah, okay, yeah. Let's go back to the beginning. Yeah.
I mean, I remember I'd also, another practice I worked at, I used to work in places, I didn't see clients, I didn't consult. Yeah. My job was to sit in a back room and I'd get a consent form signed. Yeah. It's crucial, in GA sort. That would be like that. Quote, £2,000. There you go. Yeah. And then I'd sign a thing, and that was what I get. And I history would be fairly minimal, but it would be some history maybe, if I'm lucky. And I used to do telephone consults and phone owners up. And I used to do the phone consultations from the point of view of actually pretending that the vet who did the consult was absolutely clueless. Yeah. And trying to actively disprove what they thought was going on. Yeah. Because I figured that was the safest way
to get through that.
To get through it and out the other side with the right diagnosis rather than just taking it as read. Yeah. And I mean, I think I sort of do it now. If I see someone else's, if I see your complication, not that you have complications, obviously it's like ever happens. But if I were to, I mean, Hella's frozen over and you've got an infection on a TPLO or something.
Yes, well, yeah. How could I get that 5%?
I generally basically take it from the point of view.
I think at this stage I call you an ass.
The first point, I think, is whatever's Arthur's written, I'm just going to feel the opposite or actively ignore.
As you always do, yeah.
But that's
you
it's
started
the safest.
this.
Well, I did, but it's the safest way.
Yeah, absolutely.
It's the safest way.
Don't worry, I do the
same
to you.
Oh, good.
When
Excellent. Glad to hear it.
You never had complications.
But there's actually no notes written if I've done it. So.
Yeah, so no. I'm glad you acknowledged that.
So it's easy.
Anyway. Well, I don't get sidetracked then. I have to start from the beginning.
Exactly, you do. Yeah. I'm just thinking about you. Anyway. Starting from the beginning.
That threw you right off, didn't it?
It's important. It is
really important.
Because you're going to miss something if you don't.
And the other one too is, and it can be frustrating, so they may have gone to various centres, is getting all that information and then actually looking at the radiograph and the CT or whatever's been done. It's I think, well, we have obviously, long consultation periods, 45 minutes, which often get stretched out to an hour in this time. But there are times where you pretty well have to say to the owner, well, this is where I can get to, but I actually either need you to go away and I need to collect more information from the various sources, or we put your dog in hospital and we'll have a think about this and get back to you. Yeah. And I do find that the starting from the beginning as well, often enough, it's like, I need to admit your dog, but I don't have a plan. I don't know what it's going to cost. Yes.
You're in GA sort as well, aren't you?
Yeah. That's right. Yeah, in GA sort, yeah. And it may well involve imaging, but I just need time to get my head around this. Yeah. And I'll give you a call, or we'll do it tomorrow, whatever. But
Yes.
yeah, you got to start from the beginning. You can't solve the problem quickly.
No.
Yeah.
Not at all.
You really got to go, yeah, it's going to take time and there's going to be a fair bit of stuff to work through.
Yes.
But I do find the biggest error is getting led down the path because those preconceived ideas.
Yes.
Isn't video awesome? Mobile phones, hate them, but I do love what they've done for us as clinicians because pets can't talk.
Yes.
Here you go, this is what it does at home. And you're like, that is not what I thought you told me.
Yes.
Yeah.
No,
so going away and getting that sort of information can be super useful. Could you go home and video your dog for me? Yeah.
Totally. And it is something we do all the time.
Yeah.
There's not a lot more considerations here. I think I just wanted to add a little bit sort of expectation management and a kind of a hint of being honest as well. It's sort of there are situations where the client may well be better off going back to where they came from.
Yeah, absolutely.
You know, I from every point of view, from the satisfaction of, you know, just silly, stupid things like taking plates out of fractures that have got infected, you know, why get involved?
Well,
if it's as simple as that.
Well, but I think that's about as well just remembering complications happen to you as an individual. And so if complications come to you from another person, well, that could have been you.
Yes.
So if that owner is often just looking for reassurance and to have confidence to follow the directions that or the management plan they've been given by the initial primary surgeon.
Yeah.
And you say, if it's as simple as taking a plate out, it's like, yes, I would take the plate out.
Yeah.
The guy down the road can take the plate out.
Yeah.
If I was you, I'd talk to them. I'm sure that's what they want to do for you because they're a human being. They're going to want your dog to do well. Yeah. You know, you don't need to grab that and go, oh, well, I'm the hero.
Yes.
I'll fix it. Don't you worry.
Yeah. And as, you know, as tempting as that may be, it's just not the way.
What's it about capes and superheroes?
I don't know.
Oh, there's many quotes about them. It's in there in various films about how they get, you know, always goes wrong.
Yeah, okay.
Don't worry, Kate.
Thanks. That's a vivid mental picture. But no, I remember doing that a few times. Just go back, please.
Yeah,
you know,
absolutely.
And I would then generally call the surgeon involved and say, hey, I've just seen this case. You know, I agree, or I would suggest you think about something else or whatever. But I agree. Typically, it was all the same, and I've suggested that they, you know, I would normally say, if I reach out, I'm sure that vet will call you and actually then talk to the phone. The guy
exactly.
And
I mean, of course, you get situations where people, for whatever reason, they're not going back, and then it's a case of doing the right thing for the pet, but also I just can't see the point of lingering in the past. You know, yes, there are owners who really want you to have a discussion about what happened and how on earth this could have occurred, and you know, go down the path of a blame game, but it doesn't make the owner happier, and it certainly doesn't fix the pet. So I often say to people, look, you're here to look forward, you know, so that we can look forward together to find a solution.
Yes.
There's no value in me going back over how you got here.
Yes.
Apart from trying to work out what we're going to do.
Yeah.
It's a completely pointless discussion. No one's going to be happier for it.
Yes.
And it doesn't help. So here we go. We're going to talk about what we're going to do, not what's happened. Yeah.
I also had two other points here. With really, I mean, referral on is also an option, obviously, in these cases, and you're doing a good job if you've directed traffic in the correct way and the case gets managed adequately.
And on that, some complications are purely because can be a misdiagnosis or because that case was on the edge of your expertise.
Yes.
So you've done a cruciate surgery and the dog's now becoming ataxic. Yep, maybe it wasn't the cruciate, but it needs to go on to the neurologist.
Yes.
There are. I can't think of one on the top of my head, but that does happen, doesn't it? It's like, the reason for on referral is that has changed.
Yes.
It's no longer something that you've got the expertise to manage.
Yes.
Yeah.
And then the final point I had here was, linked in with that is what can you add to this situation?
Yeah, great question.
And being honest from that point of view is probably important. Like we've alluded to a little bit, it's quite tempting to play the hero.
Yeah.
To put the cape on and go, oh, yeah, I can sort this for you.
Yeah.
You know, and in one case I remember a long time ago, the other vet said something along those lines, and if it doesn't work, I'll do it for free.
Yeah.
So,
Not good. Yeah.
But be having a general appraisal, which comes with all of this is a process, and your first process is you're looking through the history and you're considering the case in detail because it's complex. It's more complex than it was when it first came in for surgery because things have happened.
Yeah.
So in the time that you spend managing your new case, which is a complication that you're managing, one of the things might be just an honest appraisal of where am I in this situation, and is it something I can help as much as we all want to?
Yeah.
Sometimes,
or is there someone else who's better suited? Yeah. Or is there actually a collection of people who are needed?
Yeah.
I mean, we have those ones too, don't we? Where it's like, again, around expectation, what we can achieve is diminished, but our best outcome is you need to be recruiting this person and that person and another person. It's going to be a team to get us through.
Yeah.
Is that what you want to do? Because that's the other thing, isn't it, that owners are looking for? It's some idea of what's going to be involved. It's not necessarily financial either. It's like, emotionally, time, what does that pet have to experience? Yes. And that obviously is a very, very challenging question that we can't always answer, but we do have an idea in our head of what are we going to go through. And experience goes a long way with this, doesn't it? I mean, there's certain patterns that you've had to deal with before, and that is going to be really tough.
This is a bit of a statement, but I remember when you first joined ERH, way back in whatever it was, 18 probably. And you arrived, and I was happily cutting my TPLOs, my patellas, and doing the occasional fracture and what have you. And Arthur arrives, and 98% of his original consultations were tertiary or quaternary referrals. It's like literally he had days where it would just be, I'm just going to have to say the honest truth because no one's actually said it yet.
Yes. Yeah.
That this isn't going to go well.
Yeah.
It's challenging. And looking back, I think there probably was a statement about how people were trusting you was actually the one thing they would send you. They wouldn't tell you a TPLO because maybe they're just happy sending you down to wherever you were previously.
Yeah.
They did actually want you to manage the thing which is really challenging. And those recognizing that is a challenging thing.
Yeah. Well, I put a lot of value on that though. It's like, here's the honest truth. It's as best as I can tell you. Yeah. There isn't a magic answer. I know you're looking at me with, a hope and an expectation that I'll say, yep, I can do that, but deal with that. But sometimes that's not going to be. And it's giving them enough information that they can choose. As an owner, you can choose for your pet. Is it good enough? Yeah. Yeah. It's like that discussions we have when we're dealing with pets, end of life disease, trying to counsel them through. At what point do you say, I'm comfortable letting my pet go now because it's not enough life anymore. But, those really complicated situations, trying to navigate through that, it's always challenging. Yes. But, at the end, people are super grateful for it because you just told them the truth. Yes. Yeah, here it is. Absolutely. This is where we're at.
And there are cases where that is where you are. And trying to recognise that. Yeah.
I remember actually his story from the UK because I always found in the UK no one wanted to say the word euthanasia. No. So
except before Christmas.
Except before Christmas, exactly. Yes.
Deeply inappropriate.
No. There's a syndrome in the UK which is the week before Christmas, all the very geriatric and really not doing very well pets are brought to the vet for euthanasia because the family's coming over and they don't want the family to see that pet in disarray. But anyway.
Sorry, that was...
Edit in or out as you wish.
I might be edited out later.
No. So on the complication front, an experience in the UK was a dog came in to see me and I cannot remember what the disease process was or where it was, but it was awful. And I went through the process, sat down, it was a long consultation, worked out where it had started, what had been done, what the dog was doing now. Yeah. Had a management plan, and I said to the lady, it's okay if you choose euthanasia. And she burst into tears, gave me a great big hug and said, you are the first vet that's given me that as an option. Yeah. That's what I'd like to do. Yeah. And the gratitude and relief was like, yep, you really do have to offer the spectrum. Yeah. From the, to the very, very fancy through to the simple through to the unfortunate choices.
Yes.
Yeah. And it really stuck with me. It's like, and to me, I sort of, maybe the slightly rough around the edges Aussie. It's like, well, obvious, but but it was a really good lesson. It was like, okay, that's part of our job is putting out those, putting out the spectrum of options and being really honest about it, and acknowledging when you don't know too. Yes. Like, I'm going to go and talk to other people because I'm not sure which way to jump on this. Yeah. Cool.
I think we've I hope you found that interesting and useful. I think it's a topic that isn't often discussed, but I feel it's something that we all have to manage. So thank you for that, Arthur.
Thank you, Chris. Now, for the audience, the great sadness, Dr. Chris is heading off to Melbourne University to become head of. Am I allowed to say this?
I think you are.
To become head of surgery.
Yes.
Yeah. Well done.
Thank you.
That's a huge achievement.
I'm looking forward to it.
Yeah. So we won't have Chris in the clinic, but considering that we can dial in to do podcasts, which would be quite chaotic because we won't get the timing right, I'm sure.
We've taken 18 months to actually get us in the same room.
Yeah, exactly. So, if you wait another 18 months, you might get back to it. So I would absolutely formally like to invite you to be part of this and continue to be, well, not to be part of this, to continue to be part of this. And it's fun.
Yes.
And good luck.
Yeah, thank you very much.
With all the future plans.
And thank you.
Yeah.
For everything over the years.
Yeah, it's been good.
Yeah.
All right.
Cool. Awkward pause.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.